Good evening. I'm going to talk to you today about the use of the Ilizarov for deformity correction. I will start first with some concepts related to deformity correction, and then I will go on to the use of the Ilizarov in that. So, many of the deformities that we get are related to malunited fractures. And so that's what we will concentrate on this. But the same principles can be applied for de novo deformities like congenital deformities, etc. Now, basically, concepts do not change. Methods for correcting deformities may change, especially when we get better implants like lock plates and things like that. But the planning is still that basic Ilizarov 3D mindset planning. And one of the best books you can read for this is Dr. Paley's book on planning and osteotomy rules. So the first thing we have to know is where is the deformity? There are three components: angulation, translation, as well as rotation. And one may find that, what seems like the same angulation in these three, because of the translation, the cora changes as pointed out by the green arrow. In the first instance, it is on the distal fragment. Here it is on the middle fragment, and then it seems to be in the upper fragment. And that's because of the associated translation. So in simple malunions where you have good skin, no infection, and the non-union is diaphyseal, one can do the planning in terms of either the mechanical axis as seen in this on the left side, or the anatomic axis, where we are doing the center mid-diaphyseal lines. Both of them will give us the same point of intersection or at the same level. And this is known as the cora, the center of rotation for angulation. If you do an osteotomy at this level and do an opening wedge or a neutral wedge or a closing wedge, you will get only angulation at the fracture site, and the two axes will be collinear. So this is known as osteotomy rule number 1. When the angulation and osteotomy, the osteotomy and the cora are at the same level. Now, a corollary to that is, if the cora is away from the original fracture, like you see here, pointed out by the white arrow, then there must be some translation of the fragments. So in the diaphysis, the shaft of the femur or the shaft of the tibia, the anatomic axis is straight. And in fact, the nail aids correction. The only thing you need to watch for is rotation. So in this patient, what we did was we took out the plate, did an opening wedge osteotomy, and put in a nail. And he healed with good function in that situation. Here's another one who has a biplanar, or what we call actually a oblique plane. That is, he has an apparent flexion in the distal thigh, and he also has a valgus deformity. The cora is pointed out by the orange arrow. So if you do the osteotomy at this level and put in a nail after appropriate reaming, you can get a correction in both the lateral as well as the AP. Right? So this is still osteotomy rule number 1, where the cora and osteotomy are at the same level. That's his X-ray after 2 years. Now, rotation is also a deformity. And this patient had a varus in the shaft, as you can see over here, and the foot is turned internally, so she had an internal rotation deformity. We did the osteotomy at that level and corrected the varus as well as moved the foot externally, so she got appropriate correction. So most malunions that we get, we can apply osteotomy rule number 1. So here's another patient who had a cloverleaf plating following a fracture. And because this was not a locked plate, he had a progressive varus deformity. Came to us with pain in the knee, and this is what he was at presentation. So there was an adherent scar over there, and you can see the prominence of the distal portion of the plate. Now, if you do the planning for this X-ray, which is united but malunited, you will see that if we've done an anatomic axis planning. So the red line is the mid-axial line of the proximal femur. And this blue line is a line which is 81 degrees to the distal end of the femur. And the cora is obviously at the fracture site. So here we use the plate itself as a reduction tool. On the left side picture, you see that we've only fixed the distal fragment. After fixing the distal fragment, the plate is standing away from the bone. And then we did the osteotomy and brought the plate to the bone. And with that, we are able to get a proper realignment of his limb. So that's his post-op X-ray. That's 5 months post-op, healed well on AP as well as lateral. And this was the flexion that he had. He was not interested in, any further surgery. So he was quite happy with this. So basically, osteotomy rule number 1, if the apex of the deformity and osteotomy are at the same level, there is no translation involved. And in the metaphysis or the diaphysis, if the anatomic shape can be restored, either a nail or a plate, depending on what you need to. So in the first 2 cases, you saw a nail, and in the last case, you saw a plate. But when the deformity is close to the joint or the cora is close to the joint, there are some other issues which come up. In that case, though the cora is low down, you obviously can't do the osteotomy over here, and the osteotomy has to go at a higher level, right? So when the osteotomy level is different from the cora, to get the axes aligned, there will be some translation at the osteotomy or the fracture side. Since we are correcting the deformity, it would be the osteotomy side. And that is what happens in these juxta-articular deformities. The cora is down here at the level of the knee. The osteotomy is higher up. So to get your axis properly lined up, there has to be a certain amount of translation that happens in this area. So here's another patient with a femoral shaft malunion who had varus and procurvatum and apparent shortening, right? So on the left, you see the AP, on the right, you see the lateral view. And those are the anatomic axes that we draw. So the problem here is, at the level of the cora, the bone is quite sclerotic. And this patient had internal fixation, which had some infection. So we were wary of doing an osteotomy at the level of the cora. And we decided to do the osteotomy slightly lower down, somewhere over here. So what we did was we used a regular fixator, a unilateral fixator, with the pins perpendicular to the shaft at the proximal fragment and pins perpendicular to the shaft at the distal fragment. And this was done before any osteotomy was done. If you look at the end-on view over here, you'll notice that the pins are all in the same plane so that no rotation is introduced. But when you look at it from the front, the pins are angulated towards each other. So when an osteotomy is done, the appropriate translation is done, as you see in the lower 2 pictures. And these pins are brought onto a straight fixator, that is a rail. And that shows that this is well aligned. And despite the fact that there is translation, if you look at the overall axis from the piriformis to the center of the knee. That is a straight line if one were to sort of hide this portion. And that's how he healed without any trouble. So if the osteotomy is away from the cora, then angulation as well as translation is needed for proper axis correction. In the metaphysis, a nail is possible. In the diaphysis, obviously, because of that translation, a nail is not possible. Now, let's come to the classical Ilizarov, right? Where we put on rings and we put on hinges. So this is a girl who had a significant bowing deformity. She came with pain more on the right than on the left, medial joint tenderness as well as in-toeing. So if you see the planning, you notice that this LDFA, the lateral distal femoral angle, is abnormal. That means there is some varus in the femur, distal end of the femur. And the MPTA is also abnormal, 73. The LDTA, lateral distal tibial angle, is also abnormal. So she has some deformity in the proximal tibia, some deformity in the distal tibia, and some deformity in the femur. And we derive the cora point by drawing a proximal axis, which is this blue line along the mid shaft, and this green line, which is again the anatomic lateral distal femoral angle. This is at 81 degrees. So this is where the cora is, and this is where we'll be doing the osteotomy. Now in the femur, I can very well use a lock plate and get away with that without any trouble. But in the tibia, using any form of internal fixation is going to be difficult. So there we will use a fixator. And this is the simulated correction. Once we've done the correction, you can see all of the numbers are in the green range. So she had a right distal femur osteotomy around 4 months back before she came to us. And this is what it looked like. So you can see while the patella is looking forward, the feet are inward. And even if you look at the thigh foot axis, both the legs show internal rotation, right more than the left. This is how she was walking. And that's her that's her pre-op x-rays. On the lateral, there is no real deformity. Most of it is in the coronal plane of varus deformity. So to do the planning, again, we draw a proximal axis that is relative to the joint line. This is around 90 degrees, this red line. Distally, the green line is again at 90 degrees to the ankle. And the blue line is the midline of the shaft or the mid diaphyseal line. Now, so you get one proximal cora and another distal cora. And if the osteotomy is done at both of those levels, the axis is appropriately corrected. And as you can see in the full length X-ray, the leg becomes absolutely straight. So that's what we did. We put on the Ilizarov. So we create a bent frame to mimic the bent leg. If you see the proximal most ring over here, it's parallel to the joint line. If you see the distal most ring over here, it is also parallel to the joint line. And there are hinges. There are hinges over here as well as here. Now the cora was at this level, and the osteotomy, because we wanted good fixation, is slightly distal. So osteotomy rule number 2 comes into play. And because we are using a fixator, we don't need to worry about how much translation, etc. The fixator will kind of accommodate for that as long as your fixator is put on properly. So at the end of a month with gradual distraction, this is what the full length X-ray looks like. So that green line is the weight-bearing line of the limb, and it is passing perfectly through the center. So there is some opening out onto the upper osteotomy and some opening out and onto the distal osteotomy. Now you can see that the leg is straight, but the foot is still internally rotated. So that also needs correction. And probably the best way of correcting that is through what we call a 6-axis. You may have heard of the Taylor spatial frame, etc. So similarly, we have a 6-axis system made in India, which is called the DefFix. So the DefFix is useful, most useful for rotational correction. It is useful for angular corrections also, but most useful for rotational correction. So there, and this is a computer-driven correction. So we enter in, what are the corrections needed. The software gives us the way the struts have to be changed. And if you notice over here, there are 3 outlines. One is a yellow outline, one is a blue outline, and one is a red outline. So these are 3 stages of the program. First, we just distract the bone. Then we do the rotation, which you will notice over here is around 25 degrees. And at the end of that rotation, we get both of the fragments together again by compression. As you notice here, lengthening minus 15. So we are going to compress it by 15 millimeters. So at the end of 2 months, with that program, this is what the X-ray looks like. You notice that this has now compressed. And if you see the center bolts on the proximal ring and the center bolts on the middle ring and the distal ring, they are skewed to each other in comparison to over here, the earlier X-ray, where the center bolts were in the center. Both of them are well aligned. So we have now achieved external rotation of the tibia, right? And this is what she looks at. So we've locked her at about 184 degrees. We didn't do 180 degrees because she already had the beginning of medial compartment osteoarthritis. So we want to go into a little bit of valgus to correct this. And that's, you see the 6-axis system between ring number 1 and ring number 2. Walking quite well with the fixator. And the other thing to notice is the fact that the foot is now straight and there is no internal rotation. Now, one may think that, oh, how can you create translational deformity? But if you look at this, where I've put in a white kind of rectangle to hide those fracture areas, the overall alignment in between the proximal end of the femur, the proximal end of the tibia and the distal end of the tibia is quite straight. So this translation of that middle fragment does not really affect the biomechanics. And that's her walking at the end of 4.5 months. Once that was done, so then we planned for the left side femur and tibia correction in the same way. She didn't have as much of a rotational deformity over here. So the same thing, we draw the proximal axis that is 90 degrees to the joint line. We draw the distal axis that is again 90 degrees to the ankle joint line. And this blue line, which is kind of in the center. So it intersects over here. It intersects over here and it intersects up there, right? But because we want good fixation over here, we are going to do the osteotomy lower down and this osteotomy slightly higher up, right? And the femur, again, we are going to do the same valgus correction with a plate. Very, very similar looking simulated osteotomies. And you notice again that these numbers become normal after the correction. So we put on the Ilizarov, same principles, proximal ring parallel to the joint line, distal ring parallel to the joint line over here, hinges both between ring 1 and ring 2, as well as ring 2 and ring 3, with gradual correction that on the extreme right, you see a X-ray which shows just prior to the beginning of correction. And this is 1 month after correction. She didn't have much of a rotation over here, so we got away with just the angular correction in terms of the rotation. You can see the patella and the foot are facing straight forward. And those are the X-rays at the end of correction. Now we have distracted a little to ensure that the ends don't kind of catch on each other. And at the end of it, all we have to do is compress it till the two bone ends are coming into contact. And then finally, we do a full length X-ray again to confirm two things. One, what is the alignment? You can see the dark blue lines are what we call the HKA, hip knee angle, which was 182 on the left and 185 on the right. And the lengths were practically equal. One was 66.9 centimeters, the other was 66.6 centimeters. So practically speaking, they are equal. And then despite what one may worry that, oh, when there is translation, will there be healing? They heal pretty well. And you can see over a period of 5 months, there is good solid healing in both the proximal and the distal osteotomies on the AP as well as on the lateral. So that's the distal osteotomy showing its healing on the AP, distal osteotomy in the lateral. And this was at the time of fixator removal of the left side. This is how her, this slide should have come earlier. Anyways, that it shows you how she has progressed from weight bearing with a walker to weight bearing with a single stick. And at this time, she's good enough for removal. This is a comparison between what she was walking before and walking after. So she's got a significant improvement and she's pretty happy. Now, whenever there is varus as well as rotation, as I showed you in that earlier case, you notice the difference with the foot forward on the left side and with the patella forward, which is the way that we ideally should do it. You notice that there is much more medial deviation of the weight-bearing axis. So here again, the cora is up there. The osteotomy or the fracture is over here, and we are going to do the osteotomy lower down. Why lower down? Because I want good fixation in the proximal fragment. So to get that good fixation, I have multiple wires, multiple Shan screws, and then I keep a safe distance so that the osteotomy doesn't shatter into the pins, right? So we've got a 6-axis system over here, which corrects both the angulation as well as the rotation. Notice in this picture, with the patella facing forward, the foot is turned in. And in this picture now, with the patella facing forward, the foot is facing straight. As well as the red line shows that the weight-bearing axis is well restored. Once the correction is done, we can take out, or rather we can replace the 6-axis system with the regular rods, because now we just have to hold the first ring relative to the second ring. We don't have to do any manipulation. So, especially if the original fracture site is technically demanding, or if the original fracture site has poor soft tissue or sclerotic bone, we can do the osteotomy away from the cora, as long as you remember osteotomy rule number 2. Now, the tendency whenever there is a complex deformity is to think that, oh, only the Ilizarov will correct it. So here's a patient with fibrous dysplasia. who had a pretty severe deformity in the femur, right? And one would think that Ilizarov would be the right, but in fibrous dysplasia, intramedullary implants are the best. Now, these are just other views of her issues. So the point is, you need to understand the deformity and then use whatever is the appropriate tool. So now here what we've done, and analysis basically makes you think. You're kind of performing the surgery out of the operating room. So now here we've got one blue line, which is the mid-diaphyseal line of the proximal femur. We've got another line here, which is the mid-diaphyseal line of the middle part of the femur, shaft of the femur. And another 81-degree line, which I told you, which represents the axis of the distal femur. So you will see that there is one deformity over here. There is a varus of the hip. There is one varus deformity over here. And if you forget about this, you will notice that the distal femur in relation to this shaft is in valgus. So you've got three things to do over here. So we decided that the hip, we are not going to deal with right now. We are just going to correct the shaft. So proximally, this boils down to rule number 1, because the cora is at this level and we are going to do the osteotomy at this level. Distally, the cora is down here, that spot that you see. And the osteotomy has to be done higher up so that we have enough distal bone to have purchase. So that's the axis planning. This is the simulation of correction by cutting out appropriate wedges. And ultimately then, to do this surgery, all we have to do is follow the plan. So what we did was proximal reaming, did the proximal osteotomy, which was quite a large wedge which had to be excised. So that wedge has been excised. And in this case, because there was fibrous dysplasia and there had been a nail inside, we made an entry through the distal femur for the guide wire so that the guide wire lands up in the correct center point. If I had gone from above, it is very likely that the guide wire would have just followed this same track and landed up on the lateral aspect. Now that would not allow for full correction. So therefore, we went in through the distal femur through a small incision at the level of the knee, put in a guide wire from there, from below up, and then reamed over that guide wire and put in the nail from the top over that same guide wire. Right? So now we've got the translation that we required and we've got the correction of the angulation. So on the left, you see the plan that we made. In the middle, you see the post-op, the middle and right, you see the post-op x-rays that we had, which to a large extent mimicked exactly what we had planned. So the execution is less important, I think, than understanding the deformity and the planning. If you understand the deformity, it's not very difficult to carry out those steps. And that's a post-operative picture. That's her post-operative function. At 16 months, she was well healed without any trouble. She had a remaining equinus, which we did at a second stage, which is why you see the plaster cast. And yeah. So what you use exactly for correction and whether you do an acute correction or a gradual correction really depends on your understanding of the issues involved. Internal fixation is much simpler for the patient later, but there's hardly any room for error. It requires a lot of hard work preoperatively as well as intraop to get the alignment exactly the way that you want it. And if you do an acute correction, sometimes, especially valgus to varus, excuse me, there is a risk of neurodeficit. External fixation, the advantage is soft tissues are not a problem almost every time. And you can decide whether you want to do it acutely or gradually. Mostly, if you put on an external fixation, I would usually prefer to do a gradual correction. So in conclusion, you got to have proper imaging, both preoperatively as well as intraoperative. You got to have a proper understanding of deformity principles. As I told you, osteotomy rule number 1, osteotomy rule number 2. You need to plan the correction and simulate it with paper cutouts and things like that. Execute it properly. And which implant is actually the last decision, so to speak. And that depends on the location of the deformity, whether it's in the diaphysis or the metaphysis. As I said earlier, diaphysis can be well corrected by nail oftentimes. If it's the metaphysis, you may need to use a plate or an external fixation. It also depends on the soft tissue condition. If soft tissue conditions are good, internal fixation can be used. If soft tissue conditions are not good, then external fixation would be the better idea. And the local bone conditions, right? So for any surgical method, when to do it, more important is when not to do it. And I think there is a saying that the best surgeons know when not to operate, how to do it, and always have a plan B in terms of if you land up with trouble. If this happens, what am I going to do? If that happens, what am I going to do? Kind of situation, right? Thank you. So I think some of these concepts you can also see in our on our YouTube channel. We have a playlist which is titled Deformity Concepts or Deformity Planning, I think. So many of these things are explained much more in detail over there if you're interested. Thank you.